Could you please explain how to manage submucosal fibroids?
Yes, so among all these fibroids, we really don't like submucosal fibroids. All the fibroids we try to ignore, but the submucosal fibroids we cannot ignore because they can reduce the chance of implantation significantly, depending on the size of those fibroids, again, number of fibroids and location of those fibroids. So because, let us say, if you imagine uterus like room, you have got endometrial lining, which is like a carpet layer of the uterus where implantation should take place. If you have a fibroid protruding into the cavity, so embryo can simply implant on that surface where fibroid is. Fibroids do not have any blood vessels. If embryo implants on top of the endometrial lining where the fibroid is, initially it can implant and you can get pregnant, and as it starts growing its placenta, then it cannot grow placenta. Then you can have a biochemical pregnancies, in certain cases miscarriages. So, and also when you have a fibroid, it's like foreign body. Uterus keeps contracting because of foreign body. That means embryo cannot settle during implantation properly, because all the time you have a wave of contractions happening. So for that reason, we really want to deal with the submucosal fibroid before we transfer. So essentially, you can have a medical management. If you have a very large submucosal fibroids, then you can treat that by shrinking the size. Usually you use generic analog like Zoladex to shrink the size. Let us say you have got a 3 centimeter submucosal fibroid, which is type, I will explain the types. Let us say type 2, you cannot remove surgically, which means you can use Zoladex, for example, reduce the blood flow to that fibroid, reduce estrogen levels so that it will shrink and move away. So this is one type of treatment. Second type of treatment is you can remove the fibroid. So by doing myomectomy. So myomectomy means open surgery or keyhole surgery. You come from outside the uterus and chill out that fibroid. Or if you have a type 0, type 1 fibroids, you can remove with a resection, with hysteroscopic resection. You come from inside, then you just cut the fibroid using hot wire. So very importantly, you need to establish what kind of fibroid it is by doing deep pelvic ultrasound scanning or MRI scan. So then sometimes it requires doing hysteroscopy to be really sure about the type of the fibroid. So type 1 submucosal fibroid means most of this fibroid is protruding into the uterine cavity. Fibroid always grows from the muscle layer. So the difference between polyp and fibroid, polyp grows from the endometrial layer, endometrial plate, fibroid grows from the muscle layer. So in type 0 fibroid, fibroid grows from the muscle, which is the wall of the uterus, protrudes into the cavity, and most of it is inside the cavity. So it's like kind of pedinculated in the sitting inside the cavity. That fibroid needs to be removed surgically with hysteroscopic resection, which means you have a general anesthetic, you put the camera through the cervix, then go into the uterus, visualize the fibroid, and just cut the fibroid and remove the fibroid. It's called hysteroscopic resection of fibroid. Type 1 fibroid means, again, fibroid coming from the muscle wall of the uterus, going into the uterus, and more than 50% of the fibroid sitting inside the cavity. Less than 50% is sitting in the wall or myometrium muscle layer of the uterus. Those fibroids also need to be removed surgically with hysteroscopy. Again, same thing, you just cut. It's a little bit more difficult than type 0, but you remove those fibroids with hysteroscopically. If you have a type 2 fibroid, again, fibroid growing from the wall, muscle layer, going into the uterus, but less than 50% in the cavity, more than 50% in the muscle of the uterus. And those fibroids should not be removed with hysteroscopy. Why? Because when you try to remove that fibroid, you dig into the uterine wall. So, which means you have a big breach in the endometrium. So endometrial plates, which is a plate of endometrium which regenerates every month, which is called basal endometrium. So that is, you got endometrial plate between your endometrium and the muscle layer. if you start cutting into the endometrial plate, you may develop big defect. So then you dig into the uterine wall to try and remove more than 50% of the fibroid. So after the surgery, that if the defect doesn't close properly, then you have a scar tissue formation. So if the defect of the endometrial plate doesn't meet, you have a big scarring inside the uterus. That's called Asherman syndrome. That's even more impactful than fibroid. It's even worse than managing fibroid because you can keep developing scar tissue, and you may need to keep doing hysteroscopy to remove that scar tissue. So type 0 fibroids and type 1 fibroids need to be removed hysteroscopically. Type 2 fibroids and all other fibroids, if they need to be removed surgically, they need to be removed by myomectomy, which means you should come from outside the uterus, not inside the uterus. So also type 2 fibroids, you can manage by shrinking them so that they will move away, especially if they're very big fibroids. So you can use, again, generic analogs, reduce estrogen levels so that they shrink and move away from the cavity and they don't cause distortion of the cavity.